Good afternoon. My name is Anat Galor. I'm an associate professor of clinical ophthalmology at the University of Miami Bascom Palmer Eye Institute, and I have the distinguished pleasure of sitting here with my mentor, Russ Van Gelder. He is a professor and chair of the University of Washington and president-elect, so congratulations, of the American Academy of Ophthalmology. So thank you for sitting with me.
This is fun. Thank you, Anat.
Okay, so a few questions. You gave a really fantastic talk today about the past, the present, and the future of molecular diagnostics and how we can apply this to study eye disease. And so I was hoping that you can kind of give us your overview of when and how do we use this technology.
Thank you. So the molecular diagnostics have been around for about 20 years now. PCR, as we know it, polymerase chain reaction, was first described in about 1985 and came into use in ophthalmology in about 1990. And in the last 25 years, technical advances have really brought it to the point where it's ready for prime time for clinical use. So in my own practice, I use it in a couple of scenarios regularly and a couple of scenarios occasionally. The scenarios I use it regularly are in cases where I suspect viral retinitis, because it's critical that you make that diagnosis appropriately. Our standard protocol now for someone who comes in with what looks like acute retinal necrosis or progressive outer retinal necrosis is to tap the vitreous or the aqueous and run PCR diagnostics for herpes simplex, varicella zoster, cytomegalovirus, sometimes toxoplasmosis if that's a case that it's on the differential diagnosis.
So is it okay to do the aqueous? Does it seem to work as well as vitreous?
Good question. So the aqueous seems to be fine for the viruses, and I don't think there's any controversy in the field that an aqueous tap for varicella zoster, herpes simplex, Epstein-Barr virus, cytomegalovirus is acceptable. It's still a little controversial for other PCR targets like toxoplasmosis or bacterial or fungal targets. And I think if the key is really to make a diagnosis in those cases, you probably want to look at a vitreous tap for those entities.
And if you're going to do it, can you kind of take me, let's say you're going to do an AC tap, can you take me through your steps from when you start to what you actually do with the specimen?
Sure. So the first thing to think about is what are we going to run on it and how much specimen do we need? That depends on what lab we're using. At University of Washington, where we have a reference lab, we need 100 microliters to run a normal suite of tests, so that's what I'll anticipate taking. Other hospitals may vary. They may want 200 microliters, and so very important before you even talk to the patient that you know what your lab needs, because that's going to affect your consent process. Then, of course, you consent the patient. One thing that I get asked sometimes is paracentesis a dangerous procedure? And there's very good literature suggesting that paracentesis as performed with a small 27 or 30 gauge needle under topical anesthesia has an extremely low risk of complications. Occasionally a little bit of bleeding if you hit the iris. Cataract has been reported if you nick the lens capsule, but is exceedingly rare in a patient who's got a normal chamber and not shallow. And can stand doing this under topical anesthesia and not freak out at the slit lamp or under the microscope. Once consent has been obtained, it's important to do this aseptically. I use betadine, so I'll numb the eye with topical anesthetic, and then use a little betadine prep as you would for surgery to sterilize or make the field aseptic. The actual needle is usually a 27 or 30 gauge. I tend to use a 30. We will usually numb up a little bit extra around the limbus with the pledget before we put on the povidone iodine. And then I take the plunger off the syringe and generally go in and let capillary action draw out 100 microliters or so. We'll then collect that sample, remove the needle, throw it away, cap the syringe, and it goes on ice. In our lab, or in our clinic, we freeze that down then on dry ice immediately and get it to the laboratory. Again, this is something to coordinate with your pathology group or your reference laboratory in terms of how they want to do it. You need to specify the tests. We always do quantitative PCR for our viruses. That's sort of the reflex that our lab does. If you're going to do bacteria or fungi or toxoplasmosis or any of these other things, you really need to, again, coordinate with the lab and determine if you want to do it quantitatively or qualitatively.
Okay. So you mentioned the word qualitative, quantitative. Can you just explain a little bit of what you mean by those terms?
Sure. So quantitative PCR is a technique. It's a special way of doing PCR where you can measure the amount of product that's being made in real time. It's sometimes called real-time PCR, RT-PCR, or sometimes qPCR for quantitative PCR. It gives you the equivalent of a titer in viral terms or colony count in bacteria, so that you can can say, I got 20,000 copies back, that's a real infection, or I got 2 copies back, that might be just a virus that's on the eye surface but isn't causing real disease. We generally do quantitative for all of our viral PCR. It's a little more complicated for bacterial or fungal PCR.
So what do you do when you get a positive result? Is it real? What do you do when you get a negative result? Do you believe it?
Yeah, so positive results for viruses, if it's a high copy number with real time, we generally believe those. There's not a lot of recreational viral shedding on the eye surface that will give you numbers like 10,000 copies per mil or 100,000 copies per mil. For bacteria, it's a little trickier. There are universal primers that will do all bacteria or all fungi. There's not very good data at this point to say what the sensitivity and specificity of those tests are. So if you get a positive test on a bacterial, you do have to ask how much bacteria is there and what is that bacterium. And most labs will sequence the PCR product to tell you that's a Staphylococcus or a Streptococcus or whatever it is. Negative results can also be a little tricky. There are inhibitors of aqueous in the aqueous in the vitreous that can lead to some false negatives. It's unusual for viral PCR, but it is seen in toxoplasmosis and some other primer sets. If you really have a high clinical suspicion that something is toxoplasmosis and you get a negative PCR, you can ask the lab to do additional DNA purification, or you can also ask for a second primer set, and sometimes those are useful. There have been reported negatives in CMV retinitis, for example, when the primer set was in an area that was mutated with drug resistance, for example.
Now, is this available to everyone? Let's say I don't have, are all these tests that you described something that's available commercially?
They are. So they are available commercially. The best thing to do is to talk to your local hospital's pathology lab. There are a number of vendors who provide those services as a reference lab. One important point is before you draw the samples off, you should know what lab it's going to, and you do need to know what the billing situation is for that lab. Some labs are able to bill third-party payers directly. Others will actually bill back to the patient and ask them to bring it back to insurance. That's not too popular with the patients. So,
any idea of how much this technology costs?
It's not that expensive. So PCR testing for viruses, for example, is in the order of $100 or less at most laboratories. So it's not a break-the-bank kind of test, but most patients would still rather not see the bill for that if that's avoidable.
So you mentioned suspected viral retinitis. Any other situations where you think this can be particularly useful?
Yeah, I do think it's quite useful in some cases of atypical toxoplasmosis, if that's on the differential diagnosis. We have been using it increasingly in cases of suspected fungal endophthalmitis, although culture has a pretty good yield, but sometimes you may not get a great sample when you do your vitreous tap. It might be loculated fungi, so that is useful. And we're starting to use it a little bit more in our bacterial testing for culture negative endophthalmitis, although the yields in our group haven't been tremendous for PCR versus culture in that setting at this point.
Well, thank you. That was such a terrific overview. Switching gears a little bit, you have a very exciting year coming up. Any particular plans or goals you hope for the next year as president?
Well, it's a great pleasure to serve as the president next year, starting in 2015 of the Academy. It's a fantastic organization. It is my hope that in addition to helping lead this great organization, that I can help foster innovation in the coming year. I think some of the technologies that we've been talking about are innovative. It's hard to get them to the clinic. The environment for innovation is not as good as it was a few years ago. I think we need to look at how we foster innovation among our members, how we partner with groups that are trying to innovate and improve care, and how we bring that all back to the patient. And that's going to be one of my priorities as president in the upcoming year. Second priority is I think there will be a lot of discussion this year about education, which is another area near and dear to my heart. We're looking at how we redo residency education. Do we need to look at how residents are trained in a different way? And that's going to be an exciting project this year, and I think we'll see a lot of motion on that front in 2015.
Seems like it's going to be a very exciting year.
It will.
So, congratulations again.
Thank you.